Good evening, everybody. We'll just give everyone a few moments to get logged in before we kick off tonight's session. Okay, I'll get started. So good evening, everyone, and welcome to tonight's webinar. My name is Dana, and I'm a project coordinator at GPEx. I'd like to begin tonight by acknowledging the traditional custodians of the land on which we meet and pay my respects to their elders past and present. I'd also like to extend that respect to Aboriginal and Torres Strait Islander people joining us this evening. So tonight's webinar is being presented by Associate Professor Eliza Werner-Seidler from the Black Dog Institute. And we've also got Dr. Alex Sweetman online, the Senior Program Manager at Australasian Sleep Association. And tonight's webinar will be covering Cognitive Behavioural Therapy for Insomnia. So this session has been made possible by funding provided by the Australasian Sleep Association and should run for roughly an hour and a half. Throughout the session, if you do have questions, please pop them into the Q&A and we'll go through them throughout the session. After the webinar as well, we will send through a short survey for you. I do request that you complete that if you have a couple of minutes. It's really helpful for us to continue to make these sorts of webinars possible and to make sure you're getting the most out of them. You'll also receive a copy of the presentation that we cover tonight, as well as any additional resources. And if you have provided your RACGP details, you'll also get your CPD uploaded for you. All right, over to you, Eliza. Oh, you're just still on mute.
Yeah, no matter how many times we do that, we sometimes still forget. I just want to say thank you for the opportunity to deliver this webinar. I'm coming to you from Gadigal land in Randwick in New South Wales, and I'm really excited to be here talking about sleep. There's just so many fascinating aspects to sleep, and I hope that you take some messages from the material that we're going to cover. In terms of the learning outcomes, I hope that by the end of this session, you are able to identify insomnia disorder and its diagnosis, have an understanding of its impact, which you probably do already, and then also understand common comorbidities. I'm going to share with you an overview of different skills and strategies, as well as the evidence base of cognitive behaviour therapy for insomnia. We're going to look at different concepts and skill development around areas of stimulus control, sleep restriction, cognitive restructuring, and ways that you can help your patients reduce their hyperarousal before bed. Then there's a huge number of resources available online and in the community in order to upskill in CBT-i or digital programs that you may wish to refer your patients to that I'll cover as well. And then I'll talk about some of the common barriers to successful treatment and how people find they can support their patients through treatment, through CBT-i. Now, in terms of how tonight is structured, so I'm going to start, before I talk about disordered sleep and insomnia, I want to talk about the importance of sleep and what healthy sleep looks like. I could deliver a whole webinar on that, but I'll just keep it to sort of 5 to 10 minutes. Then I'm going to talk about what insomnia disorder is, its clinical criteria and how to assess it. Then I'm going to spend the bulk of the session tonight talking about insomnia treatment and with a focus on CBT-i. I will touch on some other treatments, including medications, but the focus will really be on CBT-i. Then I'll share some referral options and resources. And at the end, I've left time for questions and discussion. Now, I'm going to stop in between each of these areas as well. Listening to somebody online for 90 minutes is very long. So I'm really keen to answer your questions, get involved in the chat. We'll be pausing throughout so that I can have a look at questions coming through and address them if I'm able to. Okay, so let's get into it. So I guess the first thing is, before we talk about insomnia, let's talk about sleep. And it's actually like trickier to define than what you might think. So yes, it's about being immobile, but also it's being unresponsive to the world around us. And it's a real shift in our state, but we're not exactly switched off. So the brain is actually more active when we're asleep than it is during the day, which I find absolutely fascinating. And there's a whole range of physiological processes that are going on while we're asleep. Now, Mary Casketen is a really important researcher in sleep. She works out of Brown University in Rhode Island. And she's come up with this definition that sleep is a reversible behavioural state of perceptual disengagement from and unresponsiveness to the environment. But of course, people can be woken up. So I guess that's sort of quite a broad encompassing definition. And the other thing is that until recently, we actually didn't know much about the science of sleep at all, which is really interesting because it's one of these core basic drivers of life and survival. So, next to food, sex, drinking, sleep, and eating, sleep is really important. So yeah, we know relatively less about sleep than some of these other functions, but I'm going to share a little bit about what we do know. So there isn't one single biological reason as to why we sleep. And there's a few theories that have been put forward to explain sleep function, and there's really good evidence to suggest that actually each of these three form some reason as to why we sleep. So the first is restoration of the body. So sleep provides the body with an opportunity to restore and repair itself. And this includes things like muscle growth and tissue repair. And it also allows the body to make certain hormones at night. So for example, the release of growth hormone. So that's, I guess, the first function. The second is memory consolidation. So sleep is really important for consolidating short-term memories and learning about things that have happened during the day and shifting that into long-term memory. And sleep is also really useful for getting rid of all of the material and experiences that we had during the day that we actually don't need to retain in long-term memory. So it's sort of like a bit of a filter in that way. I find a lot of university students say that they read their notes and try and learn things before they go to sleep. They put it aside and then they wake up actually having consolidated some of that material that they've learned during the day and read just before they go to bed. And then finally, sleep's really important for removing toxins from the brain, and it supports increased plasticity in the brain. So I guess that's together these are critical functions and give some clue as to why we sleep. Now I want to move on and talk about two processes that are really important in controlling our sleep and when we're awake and when we're asleep. And the first one, which is probably the easiest, is our sleep drive. So this is kind of our sleep pressure or desire to sleep. And it makes sense. When you wake up in the morning, your sleep pressure is very, very low. You hopefully are refreshed. And then actually as the day wears on, there's an accumulation in the brain of adenosine, which increases with every waking minute that passes. And essentially it's the amount of this accumulated wakefulness that increases your sleep drive. So as the day draws on, you get sleepier and sleepier, and then come nighttime, your sleep drive is at its highest and you need to sleep in order to replenish your ability to stay awake. And that works in parallel with what we sometimes call process C, or the circadian rhythm. And this is essentially the internal body clock. So we know our internal body clocks run on a sort of 23-ish to 24-hour clock. And this modulates how alert we are during the day. So it involves the suprachiasmatic nucleus, or the SCN, which is essentially the internal body clock. So it sits behind the eyes in the brain, and it's sensitive to things like light, as well as how we would, as well as cues like eating and exercise. And it sort of gives our body hints about when we are going to be awake and when we're going to go to sleep. And it's these two processes. The circadian rhythm, I should also say, mediates the release of melatonin, so as well as cortisol. So we can see how some of these processes, they work in parallel. Your sleep drive increases through the day, and your circadian rhythm, with all of those cues, including light and eating and things like that, converge to be able to allow somebody to fall asleep at the right time. Now, I'm not going to go into a huge level of detail around different stages of sleep, but I did want to briefly touch on what healthy sleep looks like. This is what we might call sleep architecture. So what happens when somebody goes to sleep? And if you this is sleep from an average healthy adult. if we have a look, they're awake, say, just before midnight, they have quite a late bedtime. They go to sleep, they'll start in the light phases of sleep, which is stage 1 and stage 2, and they'll gradually move into a deeper sleep, so stage 3 and stage 4. And then they'll gradually come out of this they'll have what's called rapid eye movement sleep. It's when the body is completely, I guess, immobile, and then they cycle through this sleep cycle throughout the night. Each cycle takes about 90 minutes or so, and the amount of REM sleep that you get becomes greater as the night progresses. I guess what's most important from this graph is that it is completely normal to wake up throughout the night. So most people cannot remember. So most people wake up, roll over, go straight back to sleep. And they can't remember. They wake up in the morning and feel like they've slept through. It's actually, most of us wake up a few times during the night, and that is a part of healthy sleep. I think what sometimes happens when things go wrong, and we'll talk about insomnia in a moment, is that people can wake up in the night, which is completely normal, but then not be able to get back to sleep. And they really kind of blame these, nighttime awakenings because they're not able to just shut off their brain, roll back over and go back to sleep. And that can be something that is a key presentation for a lot of people with sleep difficulties. So I think as a first step, educating people that it's completely normal to wake up during the night can actually be quite normalizing. And then it's just that getting them back to sleep, which can be the challenge. Now, how much sleep do we actually need? So I just want to preface this by saying there's a lot of individual variability. We would all know people who need more sleep than is recommended and people who can function phenomenally on less. But if we just have a look, and I'm just focusing on adults for the moment, about 7 to 9 hours is the recommended amount of sleep. Some people can function with 6, some people need a bit more, and your sleep need actually decreases with age. So people working with sort of older adults, as people get older, they actually need sort of 7 to 8 hours sleep, but many need less than that. So I guess it's good to have in mind what healthy sleep, what the recommended amount of sleep looks like and what the average person needs, by keeping in mind there is variability within that. Now, this is how much sleep we need, but what about how much sleep we get? So in 2016, there was a national survey run by the Sleep Health Foundation of about 1,000 Australian adults who were representative of the general population. And what they found is about half, or just under half, of adults report getting inadequate sleep with an average sleep time of 7 hours. So if you think back to the last slide, that's in the lower limit. And about 12% reported fewer than 5.5 hours of sleep with associated daytime impairment. That's a very sort of limited duration of sleep each night, and something that over the long term, you'd not be able to function particularly well with. And something that is fascinating is looking at sort of why we don't get enough sleep. So if you have a look at this, this is data from 2013. So this shows the general average over time, the general average amount of sleep that people get. So if you have a look on the x-axis, we've got years, and on the y-axis, we've got sleep duration. So as you might expect, as people, children, mature, become adolescents and then adults, their sleep needs go down. They're getting sort of, I don't know, as an adult, say 20 years old, 7.5 hours sleep goes down to about sort of 7 hours by mid-40s or so. Now, this data is not taking into account work days or non-work days, weekend days, and so on. But when we break it up and have a look at the difference between work days and free days, you can actually see that on work days, people get far less sleep, and on days that they don't work, they get much more sleep. And so there really is something about having to get up in the morning at a particular time and going to work, particularly for people who are night owls, that is really limiting the amount of sleep that they get. And I think you would probably see this in your practice, people who are really limited by external factors. They're shift workers, they have to get up very early for whatever reason, and then come the weekend or when they're not on shift work and they just sleep a lot, and that sort of wreaks havoc in your circadian rhythm. So yeah, I just wanted to share that. I think it's quite a striking graph. And then sort of anecdotally, things that you probably hear, like, why don't we actually sleep enough? Well, there's all sorts of things. There's a, poor sleep environment. I can see this person doing work on their computer in bed, which is probably one of the worst things that you can do. Caffeine in the afternoon. There's all sorts of things. Alcohol disrupts sleep. There's just many, many things in our social environments and our work environments, which we can sort of bring into the bedroom and can impact on our sleep. And I do really like this as well. So I've tried everything to get to sleep, well, except that thing where you shut off your phone and close your eyes. But hey, let's not get crazy. So I think, taking into account some social factors and, people's sleep behaviors, which are often very, I guess, sort of acceptable now to scroll through your phone before you go to sleep, use it as an alarm and things like that, which can potentially get in the way of good and healthy sleep. Okay, so now let's talk about what happens when we don't sleep. Well, I'm going to go into a bit more detail in a moment, but basically there's a significantly increased risk for mental and physical health disorders. And in animal models, obviously we would not do this in people, but a total lack of sleep leads to progressive multi-organ failure and death. And something that's really interesting is there is no health outcome that sleep is not good for. So, I'm going to be focusing on sort of mental health and touching on physical health disorders, but really getting adequate sleep affects every aspect of one's life, social functioning, health, ability to perform at work, ability to, fulfill your roles in a family. Just, there are so many, pretty much every aspect of life is influenced by sleep. And I think that's why especially over the last sort of 5 to 10 years or so, we've really seen a huge interest in the role of sleep in things like mental health disorders, because it is such a huge factor. So I'm going to pause there and just see if there are any questions before I start talking about insomnia disorder and its assessment.
Yeah, so feel free to pop those questions in the Q&A or the chat box and we can go through them now.
As far as I can tell, I don't think that there's anything in there, so I might move on, but if questions come up as I'm talking, feel free to pop them in. All right, so let's talk about insomnia disorder and its assessment. Okay, so I guess first of all, you would all be familiar with seeing people in your practice who have insomnia complaints. So in the population, about 8 to 20% of people, there's variability. This is global data. Each study is a little bit different, but basically somewhere between 8 to 20% of people will meet criteria for insomnia disorder, and many, many more. So it's somewhere between 40 to 50% will experience symptoms of insomnia, subthreshold symptoms of insomnia disorder. Now, according to the DSM, insomnia is dissatisfaction with sleep quantity or sleep quality, and it's associated with one or more of the following. So difficulty in initiating sleep, so getting to sleep, maintaining sleep, so staying asleep, in line with those nighttime awakenings, waking up and then not being able to go to sleep, or early morning awakening with an inability to return to sleep. So that's very early, not talking about 6 a.m. kind of thing, people waking up at 4 o'clock in the morning and then lying in bed for hours trying to get to sleep until their alarm goes off at 7. To get a diagnosis of insomnia disorder, it must cause the individual distress or impairment in their ability to get on with their life, whether that's social, occupational, and so on. And it needs to be present for 3 nights a week for at least 3 months. And I guess key to this is that it occurs despite the adequate opportunity for sleep. So it's not somebody who is awake, very late and has to get up early for external factors. It's somebody who has the opportunity to sleep, but is unable to for the following reasons. Now, in terms of insomnia assessment, there are some really good measures. I've just put 2 here, but I guess the beauty about these is they are incredibly brief, and there's a huge amount of research which shows that they're very reliable. They have well-validated clinical cutoffs. Now, the first one is the Insomnia Severity Index. So there's 7 items in this measure. It's freely available, and I've just popped a link there. You can get it on the Australasian Sleep Association website. And I've just put an example here of what it looks like. There are now digital versions, but when we were using pen and paper, this is what it looks like. So the patient just indicates what best describes the current severity of their insomnia problem. So falling asleep, staying asleep, waking up too early. Then they're also asked about distress, interference, whether other people have noticed their poor sleep. And it literally takes, I don't know, less than a minute to do, depending on your patient or client, and about a minute to score. So that's a really quick way that you can, if somebody presents for a sleep problem, it's a really good thing that they could do in a waiting room very quickly and very easily. There's another one, a six-item measure, called the Bergen Insomnia Scale. It similarly just measures the symptoms of insomnia disorder. Now, sleep diaries will give you some really rich data. So what happens with the sleep diary? And there's something called the consensus sleep diary, which is based on research from many different groups about what sleep parameters are important to capture. And essentially, it's asking somebody to record when they went to sleep, how long it took them to get to sleep, did they wake up in the night? If yes, how long for? What time did they wake up in the morning? When did they actually get out of bed? Did they feel refreshed? And do they feel like they had daytime impairment? And the pen and paper version is on the left, and there's now lots of digital versions. There are apps that have sleep diaries. And I guess the value of doing something like this, although it is a lot more sort of in-depth, is that you get really rich information about what sorts of sleep problems people might be having. And then you can look at, how long is someone spending in bed relative to how long they're spending asleep. How long are they going to sleep before they wake up in the night? So this can, I guess, if you're working with someone exclusively on a sleep problem, this can be a really great way to collect some data. 2 weeks of information is ideal. That's a lot for a lot of people. We've run studies where we do it for just a week and you get an indication. You really want to look at the difference between weekdays and weeknights as well to capture anything that might be going on there. In terms of a diagnostic interview, there's a structured clinical interview for DSM-5 sleep disorders. It covers a range of disorders, not just insomnia disorder. There's delayed sleep phase disorder, breathing disorders, and so on. It takes about 10 to 20 minutes in total, depending on the severity and nature of the person's difficulties. But it is very easy to run through. Again, it's really just asking those symptom questions and using a bit of clinical judgment to judge that severity. Now, I think, and ideally, you probably combine different measures, but also I live in the real world where time is very precious and you're all extremely time poor. And I would say a 7-item self-report measure, which takes a couple of minutes to do, is probably enough to give you some indication about someone's difficulties. Now, I just wanted to show this because I am a psychologist and my area of work is actually psychology and mental disorders. And I've kind of come into sleep from the perspective of the key role that sleep seems to play in mental illness. And I just want to reflect on some of these comorbidities. So in major depressive disorder, about 85% of people with MDD also will have insomnia or hypersomnia nearly every day. In generalized anxiety disorder, more than 75% of people will have some kind of sleep disturbance, and it's usually that difficulty falling asleep, often sort of turning things over in your mind before you fall asleep. In post-traumatic stress disorder, one of the features is disturbed sleep, and there's a component around sort of flashbacks and recurrent dreams. In bipolar disorder, there's a really pronounced decreased need for sleep. And then alcohol and cannabis withdrawal are associated with insomnia and difficulty sleeping. So I guess I see, there's a really good review article, done a few years ago in The Lancet, which is worth looking at if you're interested in sort of the levels of comorbidity and the features around between insomnia and sleep difficulties and mental illness. And we really see that these things kind of go together. And there's been some research trying to work out, what causes what comes first. And it looks like, based on the evidence that we have today, that sleep is often a precursor to the onset of mental illness. And we also know that the risk of, so my area is depression. We know that the risk of developing depression is more than double by having insomnia. So in all likelihood, these things are probably bidirectional, but it looks like what comes first, or at least what people notice first, is the sleep problem. So often people will say that the first thing that they notice deteriorating, they'll present for a mental health problem, but they'll say the first thing they'll notice is a deterioration in their sleep. And I think we all sleep every day. We all know what it's like to have a poor night's sleep, and it's so debilitating. It's much easier to identify a symptom of, a sleep disorder than an emotional one, which relies on emotional literacy, some degree of reflection, and so on. So I I find that really interesting. And it also is associated with much lower levels of stigma. So I actually got into sleep because I couldn't get schools to sign up for a depression prevention program that I was running, and they asked for a healthy lifestyle, exercise, or sleep intervention instead. And it sort of led me down this literature, and I was fascinated by what I found. So yeah, so I think there are many benefits in looking at sleep in the context of mental illness as well as on its own. So poor sleep, it seems to be involved in, but is distinct from mental illness. It doesn't necessarily remit following psychiatric treatment, and it also increases the risk of relapse. So if somebody has a comorbid sleep and mental health problem, if the mental health problem is treated, the psychiatric problem, the sleep problem often remains, and it's a risk factor. So it's a risk factor for incidence, but also for recurrence. So I think I've said this, that the link is likely bidirectional, but it looks like poor sleep is a causal factor in the subsequent onset of psychiatric symptoms. Now, why does this matter? Well, if you're thinking about your treatment options for someone with a psychiatric illness and a comorbid sleep problem, it's sometimes easier to start with sleep. And if you can help someone with their sleep, it actually lessens the severity of their other disorder, which is quite appealing. It might be easier for some people to engage with, at least to start, and it's seldom addressed in treatment when patients present for mental health concerns. So very few psychologists routinely assess for sleep problems, and this is a sort of a burgeoning area where there really needs to be a lot more done in psychologist education, and I think health professional education in general about the importance of sleep and mental health. Okay, so I'm going to pause there again before I start talking about treatment, which is sort of like the not fun part, but the really interesting. Dana, are there any questions that you want me to address?
Yeah, we've got a couple questions. So we've got one here, the diagram of the typical night's sleep of a healthy adult.
Yes.
That architecture of sleep would be very different in a shift worker.
Yes.
Yeah.
Yes, absolutely. So this is somebody who is not a shift worker. I mean, shift worker sleep is atypical and can often be all over the place. You don't get that sort of regular cyclic night sleep. So yes, it would look very different.
There's also another question here. What is the impact of broken sleep as opposed to getting continuous sleep if the total sleep amount is still the same?
Well, I mean, the key point there is that you really need to be getting that rapid eye movement sleep to feel rested. And so if you're not fully cycling through, it depends how much of the broken sleep you're getting. So it's really that REM and slow wave sleep that is important to feeling refreshed and, feeling well rested. And so yeah, if you also think about your circadian rhythm and your sleep drive, you can replenish your sleep drive by sleeping regularly, but it's better than not getting sleep at all, but it really depends on the duration of the sleep and the frequency of the awakenings and how long they're for, I would say.
Yeah. We've also got one here on whether you could recommend any sleep diarying apps.
Yeah, that's a great question. I will get back to you on that. I want to have a look through them before in detail. They actually change quite frequently. So there was one that I used a few years ago and I actually checked before this and it is no longer on the App Store. So that's something that I'll send around with the resources for this. I'll just make a note of that.
Awesome. We have a question here as well on how practical in clinic would you find the Pittsburgh Sleep Quality Index? They find it much more comprehensive, but is quite lengthy for patients to complete.
Yeah. So the Pittsburgh is a great measure because it looks at sleep quality more holistically. It doesn't just focus on difficulty sleeping. It covers things like sleep medications and how, like, the quality of someone's sleep, not just their duration. I think it is longer. Not hugely so. I think it could be useful if you are going to go through the answers with someone and sit with them and get all the information. It's extremely lengthy to score. So the way that it's scored is there's different components. So you can look at things like total sleep time, sleep efficiency. There's different components that you can score up. You can get an overall sleep quality index, but it's more time consuming for you if you want to score it up properly. If you want to sit with somebody and look at their answers and have a discussion about that, I think that's fine. It's also sometimes probably preferable if somebody is reporting some kind of sleep difficulty, but it may not be insomnia. It might be a bit broader than that. You're likely to capture other presentations more related to the quality of sleep and not feeling refreshed in the morning than insomnia symptoms specifically.
Mm-hmm. Awesome. And then we have another question here on whether you had a link to the structured interview for insomnia, just the format of how you had that documentation.
I mean, that has to be purchased.
Mm-hmm.
So that's licensed to DSM. If you have a license to access any of the the structured clinical interview for any disorders, then you'll already have access to that. If you don't, I would get in trouble for sharing it. But it's extremely straightforward. It maps directly onto the symptoms. If you had a guess, you'd probably get it right, but it is a licensed interview.
Awesome. And then the last question we have for now is whether people is insomnia considered a disorder for mental health care plans? I'm not sure. We can look that up if we're not sure.
It's a great question.
I can chime in and give you a definitive answer there that it definitely is an eligible condition for a mental health treatment plan. There were quite a few GPs and psychologists that were not sure of this back in 2019, 2020. And we approached the Department of Health that confirmed without any ambiguity that insomnia is an eligible condition, whether comorbid with depression, anxiety, or whether it's standalone insomnia. You can refer patients to psychologists with a mental health treatment plan.
Amazing. Excellent.
Thanks, Alex.
That is all of our questions so far.
Okay. All right, well, I'm going to push on then and start talking about insomnia treatment, and I'm going to be focusing mostly on cognitive behavior therapy for insomnia. Okay, so the first question I expect you might be wondering is, well, do I go down the psychological therapy route or the medication route? So let me show you the evidence and let you decide. So there is a huge amount of evidence showing that CBT-i is the most effective treatment in the long term for insomnia. So I'm going to show you some meta-analytic data in a moment. But basically, collectively, data over the last 50 years or so shows that there are similar effects for psychological, drug and combined treatments in the short term, so at 4 to 6 weeks. But CBT-i is superior to drug treatments alone at 6 to 24 months follow-up. So, and I'll reflect in a minute about why that might be. International guidelines all now recommend CBT-i as the first-line treatment. That's the case in Australia, Europe, America, New Zealand. Globally, this is really consistent now. I think the evidence is so rarely clear in science around different treatment options, and there are always caveats, but I think this is actually one area where it couldn't be clearer. CBT-i works, and it works in the long term if it's done sort of per protocol. I am going to pause there and just sort of say a note on medications, making full well known that I'm a psychologist and this is not my area, but I think it is important to just have a look at some of the evidence for the most commonly prescribed medications and their evidence, particularly because often patients will come to you requesting sleep medication for a sleep problem. So the benzodiazepines are definitely the most prescribed, and there is RCT data that there is efficacy in the use of benzos in the short term. And so it is recommended, like it is something that can be used for insomnia in the short term for up to 4 weeks. Melatonin, so the RCTs and meta-analyses show efficacy again for short-term use. A lot of the recommendations really focus on older adults, so sort of the over 55s. It is, like, I know it is prescribed a lot, particularly pediatrically. I don't know if that's a trend in my circles or something that is happening more widely, but I think certainly for neurodivergent children and adolescents, it's having a bit of a heyday. Dual orexin receptor antagonists. So there's an RCT that shows efficacy at 3 months and safety to 12 months. So again, that can be indicated with clinical monitoring for up to 12 months. Calcium channel alpha-2 delta ligands, you would know much more about those than me. I think that these are drugs like Lyrica, and there is some evidence of efficacy at 4 weeks, but it's not indicated for the treatment of insomnia. The same is true for antidepressants, antipsychotics, and antihistamines. So there's no consistent evidence. They're not indicated for the treatment of insomnia. Often people will be on an antidepressant and commence psychological therapy for insomnia. But as a treatment alone, antidepressants are not, don't have efficacy for the improvement of insomnia disorder. So I think it's useful to consider why these medications don't work, particularly in the long term. And the thing is that they don't actually target the underlying cognitive behavioral factors which cause and maintain insomnia. We're going to spend a bit of time talking about that, but there may be short-term benefit, but they don't address things like sleep-related anxiety. A lot of the reasons why people can't get to sleep is they're turning things over in their mind at night and unable to calm their mind and body. They're watching the clock. They don't have a wind-down routine. They're going straight from working on their laptops to trying to go to sleep and wondering why they can't just drop off. Irregular sleeping patterns, sleeping half the day on the weekend and, really short hours during the week. Caffeine consumption, naps in the afternoon. There's so many, I guess, behavioral factors and cognitive factors that medication won't fix. And so I guess what we see is people can take medication in the short term and then they stop and then the sleep problem comes back. So that's why I think, combination treatments, I think if somebody wants sort of a quick and easy fix, at least for the first couple of weeks, but these factors really need to be addressed if somebody's going to maintain gains over the long term. And if I hadn't convinced you yet, there was a meta-analysis of randomized controlled trials a few years ago. And from 29 RCTs that have been conducted globally, independent groups using different kinds of CBT-i interventions, there's a large effect on insomnia symptoms up to 12 months later. Hedges G's and effect size, we'd call 0.25 to 0.64 sort of a medium to, edging into the large range. And that's, I guess, strong evidence to support the use of CBT-i for insomnia. So what is it? It's generally a brief, structured approach, psychological approach to treating insomnia. I like it because it's very behavioral in nature. If I have somebody with a depressive disorder and comorbid insomnia disorder, I will start with insomnia disorder because it's much easier to implement. People tend to see changes really quickly. It's really great for engagement and motivation. And there's not a huge amount. There is very important cognitive components, but you can start with the behavioral stuff and get some really quick wins. The treatment overall aims to change unhelpful beliefs about sleep, reduce arousal in the body and mind before bed, and sort of alters unrealistic beliefs and attitudes about sleep, as well as more behavioral things, changing the sleep environment, helping someone set regular sleep-wake times, helping them understand the impact of napping and caffeine and other things which are sort of unhelpful to going to sleep in the evening. Now, I just thought I'd do a sort of a quick overview of the model. Psychologists love models, but this is a really useful one. So we think about insomnia as a bit of a cycle. So let's just start at the top. I would say most people who experience insomnia will say that they have thoughts at night where they're catastrophic thinking, if I don't fall asleep soon, I'm going to have a terrible day. I'm never going to be able to go to sleep. I'm going to be awake all night. This is a terrible thing for me. I'm going to lose my job, all sorts of things. And also, you probably know if you've woken up in the night or it's late at night and you can't go to sleep, it's incredibly frustrating. And things seem so much worse. Have you ever woken up in the night, it's 3 o'clock in the morning, you've thought about a problem, you've just thought, oh my gosh, it's kept you up, you've ruminated about it, eventually fall back asleep, then the sun comes up the next day, you remember the thing, you're like, oh, that's totally manageable. So I think things, it's helpful to normalize that things can feel much worse at night. But having these thoughts really lead to this sort of alertness and awakeness, that you have a physiological reaction in your body, and then you get really frustrated, you get anxious, you worry about what's going to happen. That leads to increased awakeness and alertness, and then comes the behavioral stuff. You're tossing and turning, you're getting mad, you're looking at your phone, and then you're throwing it on the floor, you watch the clock, you can see the hours ticking by, and that's only serving to sort of drive that anxiety and alertness. So people get stuck in this cycle, and what CBT-i is trying to do is actually break the cycle and deal with each of these 3 things. So the main strategies, it's a multi-component program, and the main strategies are sort of sleep hygiene and psychoeducation to start. The randomized controlled trials say that if you just do psychoed and sleep hygiene, that is not going to significantly improve someone's insomnia. So that is sort of like a necessary precursor, but it's not a standalone component. Then there's stimulus control, which is essentially really about making the bed a place for sleep and intimacy only, getting phones out and computers out, not eating and drinking in there. And I'll talk a little bit more about that. We're going to talk about each of these. There's sleep restriction, which is really about limiting the amount of time that someone has in bed awake so that they can learn to associate, they can go to sleep more quickly and sort of remove some of that frustration. Then there's cognitive restructuring, that's the thought challenging and so on, and then reducing hyperarousal, so essentially getting your body ready for sleep. So I'm going to run through each of these. I think we're going okay for time. All right, so sleep hygiene and psychoeducation, and the aim here is really to sort of change dysfunctional sleeping habits. So these are things like the environment, so making sure that people are going to bed in a dark room, that's quiet, the body needs a slight drop in temperature to fall asleep, so making sure the room's not too hot. Ideally, someone has a comfortable bed that they can sleep on. I mean, these things are not always possible. I work with uni students who are in shared dorms, and that their bedroom is literally their only space, and so there you have to make adjustments based on someone's circumstances, but sort of getting as close to like a good sleep environment is helpful. Then there's things like just general health behaviors, having a good diet, doing some physical activity in the day really improves people's ability to go to sleep at night. It doesn't have to be a huge amount, but just moving your body in some way. I think there's a bit of a misnomer that drinking alcohol can sort of help people sleep. It might help some people with sleep onset, but the later effect is that you wake up in the night, and it actually is sleep impairing. And then of course there's caffeine late in the day, which we know can keep you up, which is very useful, used tactically at times, but for somebody with difficulty sleeping should be avoided, certainly in the afternoon. And then there's behaviors. So the importance of a sleep-wake cycle. I think if there's if there's one of a few key messages to take away, it's encouraging your patients to get up at the same time every morning. Don't vary it too much on the weekend, and as much as possible, have a regular routine where you go to sleep roughly the same time each night. That really helps your circadian rhythm get into its pattern and keep that pattern. Of course, there's going to be variations, a party, an exam or something, but sticking to that as much as possible. Napping. So napping can really, if you think about that sleep drive, you have a nap, your sleep drive goes down, and then you have to wait longer to feel like you need to go to sleep again. So I guess we say, if you can avoid naps, that's good for sleep, good for nighttime sleep. If you have to nap, try make it before 3 p.m. Try make it for 20 minutes or so, just a cat nap, not a long sleep. Clock watching, we've all probably done it. it's very unhelpful. Device use, I think we do know now there are two problems with using devices in bed. One is the light, and there's differences of opinion about the impact of that. But what is clear is that what you do on your phone at night can be mentally stimulating. If you're on Instagram or you're reading the news or something fires you up, that is not conducive to sleep. And that's really at least the rationale that I use with the people that I work with about putting away phones and sort of really preparing the mind for sleep. You also don't know what you're going to see on your social media. It could be something surprising, exciting, terrible, and that's really going to kind of put your sleep plans off. The importance of a wind down routine. So doing the same thing every night, it's a real signal to your body to get ready for sleep. And then the other key thing that I would say is natural light exposure in the morning. So just, that really regulates your melatonin, makes you feel much more awake, and is really helpful, again, for sort of the regularity of your circadian rhythm. And this targets the unhelpful behaviour part of that model. Now, moving into stimulus control, the aim here is really to break the association between going to bed and not sleeping and the associated frustration and sleep-related anxiety. And so the strategies here are really using your bed only for sleeping and sex, going to bed when sleepy and getting up only when you're unable to sleep. So something that people do is they think the longer they spend in bed, the more likely it is they're going to fall asleep. And that is incorrect. Again, the evidence on this is clear. So we say to people, don't watch your clock, but if you're lying in bed, you're not falling asleep, you're getting frustrated, your mind's starting to go, get up, do something else. If you judge it's been 20 minutes, 30 minutes, get out of bed, move into a different space, do something that's calming, read, watch something boring, listen to an audiobook, and then when you feel tired, go back to bed. Try again. And that sort of avoids, spending 3 hours in bed, getting frustrated, unable to go to sleep. And then the next part is I've already touched on this, getting up at the same time each morning and avoiding. And that sort of targets both the behaviors, but also the emotional side of it, that frustration that you feel spending in bed but not asleep. Okay, so I'm going to spend a little bit of time on sleep restriction because this is often seems paradoxical to clients and patients and perhaps you. Dana, did you want to say something?
Yeah, I just thought before we move on, there was just a comment put through if there's any advice for patients who might have a partner that snores or sleep talks and they're a light sleeper and wake up every time they do that.
So the problem is for the partner?
So the patient's partner is a snorer.
Okay, yeah.
Yeah, keeping them up.
Yeah. I mean, like earplugs. I don't have any good solutions to that. I mean, there's a whole part of the internet that is about sort of, having separate beds so you can help get a better night's sleep. And there's an academic at the University of Melbourne, Dr. Bay, who has done some really interesting stuff looking at partners of poor sleepers and what they can do. There's no silver bullet. I think it's really something that has to be worked out in the couple and how disruptive it is. And whether there might be another cause for their snoring, perhaps. I'm not sure. I don't know.
Yeah, someone has just popped a comment in, send the partner to the doctor.
Yes.
Treat the snoring.
Yeah.
Change partners as well. So that's an extreme one.
I was going to say maybe change bedrooms.
Awesome.
Okay.
I think we can move on now.
Okay. All right. Great. Okay, so sleep restriction, I'd say this is probably the most difficult to implement strategy of the kind of CBT-i toolbox. And the objective here is to reduce the amount of time in bed to match the time asleep. And I'm going to go through some examples. So if somebody is sleeping 5 hours a night, say, and I'll give you some examples, but they're going to bed at 10, they're falling asleep at midnight, but they're waking up at 5 and then lying in bed till like 8 o'clock in the morning. You say, okay, you slept 5 hours last night. Tonight, I only want you to spend 5 hours in bed. And essentially what it does is it creates this mild form of sleep deprivation, which helps people go to sleep more quickly and reduces. It's really about breaking that association between the bed being a frustrating place and it reduces the amount of time really that someone can have to kind of ruminate and think about things because their sleep drive is so strong. And so essentially what it does is it increases sleep efficiency. So it increases the hours of sleep compared to time spent in bed. And I'm going to show you some cool graphs about what happens when you do this, when you use this strategy. To get someone to do this is really, really hard, and the timing has to be sort of, thought about sensitively. So obviously you have a forklift driver, you do not want to be recommending that they implement sort of, quite an extreme version of this. Same for uni students, like not around exam times. It is really hard, but it does work really well. So what the evidence says is that it leads to faster sleep onset and longer sleep duration, and it can really help to reset an out of sync body biological and circadian rhythm clock. So it can help get it back on track. Like I've said, there's less opportunity for frustration and alertness in bed, and it is effective, and it sort of targets all of these three things because it doesn't really allow people a huge amount of time to engage in that unhelpful thinking. Because they're in bed for such a limited amount of time, that becomes time that they more or less use to sleep. So take a look at this data, or this graph, sorry. So this is from Arthur Spillman. So he was a person that came up with sleep restriction therapy back in the 80s. And what you can see in this graph is this is on average what you get. On the bottom, you've got baseline days on the left. So up to 14 days, that's use of a sleep diary or polysomnography, whatever it is, just tracking someone's sleep. And then they start treatment. They start sleep restriction therapy alone, so not with the other CBT strategies. And what you can see if you just start maybe at the top is their sleep efficiency, and sleep efficiency is amount of time in bed spent sleeping, hugely increases pretty much straight away. So they're able to spend more time in bed asleep. The middle one is less compelling. So it shows that their total sleep time dips as soon as they start. So they're actually sleeping less than they were before, but then it steadily rises over treatment. But what does massively decrease is their total wake time during the night. So that often feels a lot better to people because they're not awake getting frustrated. If they're in bed, they're asleep, and if they're not, they're doing something else. If you start using this with your clients, you will see that it works, and people can see the change. And often that is really helpful because I think part of the disorder is just that frustration and that fear of going to bed. And when people are really sleep deprived, they actually sleep, and it removes some of that fear. Now I'm going to take you through sort of how you do it because I think it's probably the most complex of the strategies. And I've just got a case example. So Zara, 26, works full-time in the corporate sector, presents for low mood, but reports insomnia as a primary complaint. So you decide, okay, am I going to do a depression treatment or a sleep treatment? I go to sleep treatment and see what is left over after that. So say this is kind of average data of her sleep over the last few weeks, goes to bed at 10 o'clock, gets out of bed at 8 o'clock, but look at her sleep. So she's awake until about 12:30, then sleeps for a little bit, then she's awake again for another hour and a half in the middle of the night. That is an extraordinarily long time. And then has a good chunk of sleep from say 3 to 6, 7, and then is awake again for another hour before getting up in the morning to go to work or do whatever she needs to do. And the total sleep time there is 5 hours. So what you do is you use this to set up a sleep window. And generally you work backwards from the sleep time or the time that someone needs to be awake. So in this instance, looks like she has to be up at 7. And what you're going to do is advise that she doesn't go to sleep until 2 a.m. So you wouldn't go below 5 hours. Most people would say sort of 5 to 5.5 hours would be the lower limit that you would set for somebody's allowable sleep window, and then you're actually going to build it up over time. So basically you take the average hours slept each night over the last week to create a sleep window. So for her, it's 5 hours. You're telling her not to go to bed until 2. Chances are she's going to go to bed at 2, fall straight asleep, and then sleep through until the alarm goes off because that is a short amount of time, but no less than what she slept the previous night. And then when someone's sleep improves and their efficiency reaches about 85%, then you would increase the sleep window by 30 minutes. And that usually takes somewhere between sort of 3 to 7 nights, give or take. And what that looks like is, so for example, for this person, so you've said stay out of bed until 2, then get into bed. She spent 30 minutes awake and then has slept 4.5 hours. So if you, so basically you want to look at hours asleep versus hours in bed. So that's 4.5 over 5, and that's how you get your sleep efficiency. And when your sleep efficiency is up around 85% or over, that's when you would increase your sleep window and say it by about 30 minutes. And so the next night you say, okay, go to bed at 1:30. And once you've mastered that, then you draw it out again. And that's how you can sort of reset someone's circadian rhythm when they're in a really terrible pattern and just really do need that reset. Now, the next strategy is cognitive, so it can be more difficult, and it obviously involves some level of insight on the part of the patient or client. And the aim here is really to challenge and reality test unhelpful sleep-related beliefs. Now, from some qualitative work that we have done and other groups have done, that some of the...
Eliza, before we move on to this next one, there was just a question around why we choose to prescribe her to go to sleep at 2 a.m. when she was already asleep at 12. Just to explain that, like that 5-hour block.
Oh, yes. Already asleep at 12. Oh, I see. Because you're taking the total sleep time. So she slept 3.5 hours between, so this is her current sleep when she comes to you. So she slept 3.5 hours between 3:30 and 6 a.m. and then 1.5 hours between 12 and 1. So that's 5 hours. And you would usually base it on the time that she has to get out of bed to go to work. I mean, there's no reason why you couldn't say go to bed at 12 and then get up at 5. And if that suited her lifestyle, that would be completely fine. I'm just going on a sort of, say, a more typical 7 a.m. wake up time.
Yeah.
But yeah, you can do it anywhere in the night. I think sometimes people find it easier to stay up later than to get out of bed in the morning if they're very, very tired. But if you have that pressure of work or school or uni or whatever commitments there are, you're going to be more likely to get out of bed. Because the risk here is you say go to bed very late and then they just miss their commitment that day and keep on sleeping, and then they're not restricting their sleep at all.
Awesome. There was just a follow-up question to that. So if she agrees to trial the sleep restriction for the 5 hours and later finds that she's like super sleepy by midnight, would you keep that prescription for the 5 hours? So
I mean, it's a good question. The purists would say stay awake by any means necessary, because that's going to consolidate the sleep and make it less likely that she'll wake up during the night. I'd probably take sort of like a curious approach and say, okay, well, you know, if you're really exhausted, can you make it till 1? You know, find some middle ground. But the other thing is you also need to engage you need to engage them and keep them motivated. And if it's too hard, they will stop doing it. So I think what's important is a really strong rationale.
Yeah.
A really strong rationale, and then I guess some sensibility around, you know, what is going to be acceptable and what's not. I mean, you could try it out and see if that leads to, you know, you could just look at sleep diaries and see, okay, well, what happens when you go to bed at 12 versus what happens when you go to bed at 2, and see whether that is associated with fewer wake-ups and longer sleep duration.
Awesome. Cool. I think we can look at the next technique now.
So these are some of the most common thoughts that people have when they're frustrated in bed trying to go to sleep. I know I won't sleep well tonight. I'm going to be wide awake like I usually am. It's going to take me forever to fall asleep. If I wake in the middle of the night, I'll never get back to sleep. If I don't sleep soon, I'm going to fail my exam. One night of bad sleep is going to ruin my week. So I guess I'll go into it in a bit more detail, but the aim here really is to challenge some of these beliefs and help people test them out. So I think, you know, normalizing a bad night of sleep can be very useful. One bad night of sleep is actually not going to ruin someone's week, and you can think about ways that you might measure that or test that. So using your pretty standard cognitive challenging, what's the evidence for this? What's the evidence against this? Has this happened before? What would you tell somebody else who was having the same thought? That can be quite useful. And I guess I did want to make a distinction between general rumination and worry at bedtime versus sleep-related anxiety at bedtime, because they are related, but they are distinct. And what a lot of people will come with is this general turning things over in your mind from what happened during the day, concern about what you need to do tomorrow, that kind of general, turning problems over and over, and that's sort of keeping you awake, but it may not necessarily be related to sleep. And there's different strategies that you would use for both of these. So, like I said, for sleep-related thoughts, it's challenging those thoughts, examining the evidence, and then doing some behavioural experiments to test them out. And for general rumination and worry, I guess there's sort of addressing anxiety in general. And then some people say they're so busy during the day with all of their commitments and all the things they need to do, they wait until night to sort of think about things. And actually that can be unhelpful, because it's at night when you're actually trying to calm your mind. So for some people, allocating some time or sort of making an effort to, problem solve whatever it is that might be on their mind during the day can kind of free up their mind at night. Some teenagers that I've worked with really like this idea. There's Worry Time. There's a Worry Time app. You can just go in and write things to worry about, and you get 5 or 10 minutes to do it. It feels a little contrived to me, but it's really beneficial to some people. So I guess that's one strategy that people use. Some insight into factors that might prompt general rumination. I mean, for, when there's, political issues and things going on that people get really emotional about, like reading the news at night is just not a good idea. And I actually think distraction can be really useful at these points when we tell people to get out of bed and do something else when they can't go to sleep and their mind is racing. An audiobook, a podcast, something light, like maybe not true crime, or nothing that's too engaging, reading a book, just doing something, watching something in a different room on TV that's, a nature video, something that's boring, sort of to reset, recalm your mind, and then go to bed and do something else. Now, this is the last slide that I'm going to cover for CBT-i, and then I'm going to pause and talk about something else. I guess the last thing is sort of reducing hyperarousal, and this is like all of the sort of tension that you have in your body. And this is a really powerful predictor of difficulty, at least getting to sleep. And people often sort of report being tired but wired. And this is where things like, for those who are inclined, doing a relaxation exercise, using some PMR, doing some slow breathing, just sort of really intentionally calming the body and preparing it for sleep. Some people find exercise in the afternoons and evenings actually just increases their bodily arousal. That makes it really hard to sleep. Some people don't have that at all, but that's something to check in with. Somebody exercising every night, and is that a change to their pattern? And could that be one of the reasons why it might be harder to get to sleep? And I think to counter this, a pre-bed wind down routine is really important. So we say sort of 60 minutes or so. I mean, this is, making your kids lunch, having a shower, reading a book. It's different for everybody, laying out what you're going to wear the next day. It can be tailored to what someone does. A meditation, someone who's into mindfulness could do a 5-minute meditation, like whatever it is, but just doing the same thing every night really signals to your body that you're getting ready for sleep, and it also sort of helps to calm the mind. So I don't know. I see this. I have little children, and I do my very best to make sure they have a regular bedtime routine. And I think that adults would benefit as well. And you see when you work with people and they start to do these things, and it's predictable and consistent and the same every night, it really does help. Okay, so the last area that I'm going to talk about is looking at referral options and resources that are available. I think, we're doing well for time, so I'll pause there, Dana, and see if there are any questions.
There were just a couple more. So there was a question on how does the sleep restriction compare to setting up and encouraging a patient to set up a new sleep routine and stick to that to try to resolve their sleep issues?
Yeah, that's a great question. So I think it's got to be tailored to the individual. It can be really hard. So I work a lot with adolescents and young adults, and it can be really hard to recommend sleep restriction for adolescents as a first-line treatment, particularly because you need their parents on board. And if you tell them you're going to tell their young person to go to bed at 1 a.m., they tend not to be very happy with that. And so the way that we start is generally looking at setting up a regular sleep-wake cycle and seeing if that in and of itself is helpful along with the other strategies. And then when somebody gets to a point where nothing else is working, or it's quite severe, or they're really spending a huge amount, their sleep efficiency is so bad, they're spending a huge amount of time in bed and just really not getting very much sleep, that's when it would be indicated. You also need to think about the person that is in front of you and what they're willing to do. So I think it is not necessarily a bad idea to start. If somebody's sleep-wake cycle, you look at their sleep diary and it's all over the place, absolutely start by getting a regular pattern and see what happens to their sleep. And then, once you've exhausted the other options and nothing seems to be working, then you go to sleep restriction. I think if someone comes to you in a state and their sleep is just so completely all over the shop, it can be useful because it's just resetting everything.
Yeah. Awesome. We've got another question on how to kind of deal with a patient who might go to the bathroom regularly during the night. Does that interfere with the sleep pattern, or does it kind of become a habit more than?
Yeah.
So this example is every 2 hours they're urinating.
Yeah, look, I mean, I don't know the answer to that question. I guess from a kind of CBT perspective, if they are distressed and they're not getting back to sleep quickly after, that would be worth some consideration. I guess I'd also understand why they need to use the bathroom every 2 hours and make sure there's no sort of medical reason, or I would just want to get that checked out. If somebody gets up every 2 hours and it doesn't bother them and they go back to sleep straight away, fine.
Awesome. And then there's a question here, which I think you've covered a little bit already. It was just around how to determine the sleep efficiency and get accurate record of sleep patterns, because patients aren't always the most accurate narrators. So I think like your sleep diaries and that sort of thing you've mentioned. Is there anything else?
Yeah, look, sleep diaries and also getting them to do the sleep diary when they first wake up in the morning. So, I mean, if it's in your phone or on a piece of paper, we often recommend that it's like the first thing you do, you just roll over and you write down the time, how you think you slept, what time you reckon you went to sleep. I mean, a lot of people now use like smartwatches and Fitbits and all sorts of wearables to get some indication. The reliability of those, the jury is still out, but it can be a data source in combination with what someone reports as well. There's no way to get perfect data without using sort of, polysomnography, and people aren't going to do that in their homes. But there are some, like in sleep labs, there are these sleep mats now that you can put under your mattress, which is pretty reliable at working out when someone's asleep and someone's awake. That's obviously not something that you would prescribe or recommend to the patients that you're seeing, but I think trying to triangulate their self-report data, any kind of wearable data that they have. And actually the studies show that someone's perception of how well they're sleeping is often more closely related to like their daytime functioning than their actual sleep. So they've done these cool studies where people get false data and they're asked how tired they are. And if you show someone some data that shows that they got like 12 hours sleep of the highest quality, they feel great. And if they got 5 hours sleep and it was broken, they feel terrible. So it's obviously not as simple as that, but I think the power of perception shouldn't be kind of like thrown out. So if somebody is telling you that they are not sleeping well and having terrible sleep, the reality, it doesn't matter that much. If that's their belief, that's what you work with.
Awesome. The only other question, which might be something that needs more of a deep dive as well after this session, is I guess if you're trying to encourage a patient to pursue a CBT route, but they are often, if they've previously been using sedatives and medication to manage their insomnia, they can be quite either physiologically or psychologically dependent on these, and how to try to overcome that dependence or that maybe mentality for patients to consider other routes.
Yeah, look, I mean, if they're taking those drugs already, they're like, I guess what you don't want to do is, I was going to say you can do a combination treatment. There's no reason why you couldn't do CBT-i as well. What you don't want is for somebody to think that their sleep is okay because they're taking those drugs. You know, you want to be able to, I guess, show them through these strategies that actually you're addressing the underlying causes, and that's what is leading to an improvement in their sleep, rather than a reliance on medication. I think you would probably, you titrate it down at the same time as building up their skills and knowledge of sleep health and some of these strategies. I guess the problem with the hypnotics is you need someone to, like, you need someone to learn how to relax their body and their mind before they go to sleep, rather than relying on medication to do that for them. So I think it's probably upskilling them at the same time as also gradually, if they want to. If they don't want to engage in psychological therapy, that, like, they won't. I think you probably have a hard job of doing the sell and engaging them. And, you can always pitch it as an experiment. Let's try this for a few weeks and see, someone's not going to lose by developing these skills as well. So I think it's, there's a balance and a dance that has to be done, and working out what the client will accept and what they won't.
Awesome. There's just also been a question, so I'll just quickly remind everybody that we will send out a copy of these slides for you all, so you'll get this to reference back to. But that is all our questions so far.
Okay, all right, great. So now I'm going to show you where you can get information and refer people, and what you want to do if you want to upskill yourself in sort of becoming a CBT-i expert. So what are your options if you want to refer someone, or you want to deliver in-person treatment for insomnia? So I guess the first thing is you can deliver brief CBT-i yourself in your practice, depending on your time and the nature of the work that you do. Alex authored this great, very practical guide, a step-by-step model for brief behavioural treatment for insomnia in Australian general practice. I've put a link to that paper. It's really easy to follow. It's really straightforward. I think it's absolutely worth taking a look at. You can refer out to psychologists who are trained in CBT-i. I got to say, there aren't very many of us. So this is something that we're working on in the field. There's some brilliant sort of PhD students and junior postdocs who are really focused on upskilling psychologists in their training, but as it stands, there really aren't very many people who specialise in this area. I think if you are going to refer out, be specific in your referral for cognitive behaviour therapy for insomnia. My referrals look like depression with some sleep problems typically, and that's fine because I know what to do with that, but a lot of psychologists would maybe not. The Woolcock, I just wanted to call out, they are a sleep disorder centre in Sydney. They're affiliated with the University of Sydney. Their psychologists are all sleep psychologists, and they do both face-to-face and telehealth. So that is a good resource. In terms of resources available for you, if you want to learn more and upskill, so this is a resource from the Australasian Sleep Association. I've put a link there as well. They are great. So you can go into each of the strategies that I've just spoken about. They're succinct. There's like brief dot points, what you would do, the most important parts, how you do it. I would definitely recommend checking those out. So if you have someone, they come in and actually you think that they just need to relax before they go to bed, just go with the relaxation module. If they know nothing about sleep health, go with the basic sleep education and psychoeducation. So you don't have to do all of these all at one time, but just really match it to what someone needs. And these are really, really user-friendly. I'm guessing they must have been co-designed because they're really, I don't know. There would have been input from GPs, I have no doubt.
It's an approved clinical resource by the College of GPs, and actually Professor Nick Swar, who's a practicing GP and academic, led this one. So led by a GP for GPs. Thanks, Eliza.
And then there is a new training opportunity that's just come out. So this is run by the APS with input from ASA, or organised by ASA. So it's a self-directed online learning course. It comes with 6 hours of CPD, and it's just become available this year. So there's a link to that as well. If you would like to look at digital options, so there is a free This Way Up online course. I suspect most people would be familiar with This Way Up, or I hope you are. I'm not associated or affiliated with them in any way, but I will do a quick pitch just in case you aren't. So this is these are resources from the CRUFAD, the Clinical Research Unit for Anxiety and Depressive Disorders at St Vincent's Hospital, and they have evidence-based digital interventions for pretty much every mental health disorder, and including insomnia. There are 4 web-based lessons. The Insomnia course is free. Most of the other ones are either free or about $60, and they can be done by clients and patients in a self-directed way or clinically supervised. So if, as a clinician, you can go into the portal, make yourself a profile and actually access all of the material. So take a look. They're really good. They all have RCT evidence for them, and that's a great resource for adults. It delivers CBT-i. Now, this I am affiliated with. So for adolescents, there was actually, I became interested in this and I wanted to trial a digital CBT-i program, I guess essentially to address the fact that there aren't many clinicians that can deliver this, and there's a great need. I didn't find anything in the literature, so I developed this app. It's called Sleep Ninja. It's not for nighttime use. It's for use during the day by 12 to 16-year-olds. It's freely available on the App Store. I'll share a link in a moment. And it delivers all of the strategies that I just went through, except for sleep restriction. So in our sort of co-design consultation phase, parents told us no way. So we've gone with a regular bedtime and wake time instead. Just very briefly, I'll sort of take you through the pipeline of how this stuff gets developed, or particularly in my case. So I actually did a systematic review to find another product that I could use in my trials. None existed. So I was like, okay, I guess how hard can making an app be? I don't know if I do it again. So we did a stakeholder engagement phase with teenagers and their parents. We spoke to some clinicians as well. We developed the thing. We showed it back to young people. They told us all the things that were wrong with it. So we changed it and updated it. We then ran a pilot trial looking at acceptability, feasibility, and preliminary efficacy in the community. That showed really good effects. We then ran a randomized controlled trial with about 260 young people, and now we're sort of disseminating it and trying to get it out. I'm just going to show you, this is like there's 6 modules. We call them training sessions. There's a ninja. You become a black belt in sleep. It's all very cute. I don't know, the teenagers said that they liked it. Basically, each module takes 5 to 10 minutes to complete, and young people use this on average for about 20 minutes, all up across 6 weeks. And these are actually the effects that we see. So in our RCT, we saw an improvement, not sure why. The other group got psychoeducation, but we saw an improvement in both groups, but more so in the intervention group. And that was maintained at 3-month follow-up. So small intervention, pretty big effect. And then we also see the same pattern on depressive symptoms. So again, I think it's quite compelling. We also found that the improvement in depression was due, or 59% of the improvement in depression was due to improvement in sleep symptoms. So that was really encouraging. This is what it looks like. You can scan the QR code when you get the slides and access that really easily. Take a look at it. I would always say look at any intervention before you recommend it to a client or patient, and make sure that you think that it's good and fits what they would need. As new things come out, you can keep updated with new programs on the ASA website. On that link, they're updating digital programs as they become evidence-based and available in Australia. So you can keep an eye out on that. This area kind of is changing a lot, and I think you'll see some new programs coming out soon. And then I guess just sort of to wrap up, I did want to sort of touch on some common barriers to care. And we do have a shortage of CBT-i practitioners in the community, and it's a real problem. And I think that's where some of these digital interventions become really important. As you would know, patients and clients are much more likely to learn about sleep medication online. They're more likely to have been prescribed sleep medication before than ever have engaged in a psychological treatment for their sleep. And so I guess just to be aware and have that information about, these medications don't address the underlying causes of their sleep problems, and perhaps suggest to them that they might like to try something else. And for patients who do access CBT-i, sleep restriction can be difficult to implement. So I think the point we made before was, just personalize it, individualize it, and make sure that it fits with the person sitting in front of you. Now, in terms of addressing some of the barriers, well, I think I've pretty much covered it, like educating patients about the effectiveness of CBT-i. You can show them the meta-analyses that I've done the screenshots for. That's fine. I'm happy for this material to be used in any way that is useful and compelling to you and the people that you are helping. Refer to CBT-i practitioners when feasible, and consider digital when it's not. You're obviously engaged and interested in this area. You're upskilling yourselves in CBT-i now, and I think that is fantastic. Yeah, I've really seen a shift in at least the mental health landscape over the last decade or so towards really seeing sleep as such a powerful factor that can reduce the risk of mental health disorders, but also physical health disorders and pretty much everything else. And then supporting patients to implement CBT-i and considering the timing for implementing those strategies like sleep restriction. Okay, so this is my last slide. It's just, I guess, a brief summary of what we've been talking about. Insomnia is really common. Symptoms of insomnia are even more common. If you think it's sort of like 45%, that's like every second person at least who walks through your door. They're probably not coming to you for sleep, but they are coming to you with a sleep problem, whether they are cognizant of it or not. CBT-i for insomnia is effective over the long term. It can be delivered briefly in practice or via referral to a CBT-i clinician or digital program. I'm not going to go back through all of the strategies that we've spoken about, but progress happens really quicker than mental health, in my experience, quicker than a lot of the mental health disorder psychological treatments. And that's a really great motivator for people to stick with it. And if you can get their sleep under control, they're so much more able to engage in the other things that they need to be doing, different treatments, whatever else is going on with their lives. I think sleep is just such a basic foundational building block to start with. If you can help someone with that, everything else improves, and then you can work with, what's left over, what is the residual problem. Okay, so I'm going to stop for questions. I hope that was useful.
Thank you so much. We do have a couple questions. So we've got a question here around the Sleep Ninja app and whether the age range of 12 to 16, is there any reason it wouldn't be suitable for ages 17 and above?
Yeah, so that one I can answer very easily.
Amazing.
So there is no reason why it wouldn't be suitable for somebody 17 or above. It's interesting to me that actually our biggest user group are not 12 to 16-year-olds, they are adults. We don't know if that's parents going in and having a look and investigating it for their child or young person. There is, I think we're up to about 8,000 users now, and there is a large proportion of young people, but still adults tip that over. And we're actually trialing, so anyone can download it, anyone can use it, and we're actually running a RCT at the moment looking at its use for 10 and 11-year-olds, and we've built in like a parent module and a sort of parent guidance to support their child depending on how much support they need in engaging with the program. But if you Google Sleep Ninja, there's like an information pack and there's a special area for health professionals. So if you register, you can actually access all of the papers, summaries. There's like there's an information pack, a communications pack. There's a lot of material there that sort of answers these questions. But you have me now, so I'm also happy to answer them.
Awesome. This might be more of a question that you might have a bit more insight into, Alex. Where this particular GP online is a GP registrar at the moment and have done their own upskilling in CBT for insomnia and have found it extremely helpful. do you know if there's any headway in the GP colleges to including this as more part of their programs?
Yeah, thanks for the question, Nathan. The short answer is yes. So the brilliant presentation that Eliza's given this evening is part of a 3-year education and implementation program coordinated by the Australasian Sleep Association. So we're doing lots of different webinars, workshops at your GP conferences. I'm working with Akram to organise some webinars coming up as well. In addition to that, Eliza presented the link to a online module, an education module to upskill clinicians to deliver CBT-i, which was co-developed by the Australasian Sleep Association and the Australian Psychological Society. So that's a 6-hour program. It went live about 6 days ago, but we've just put about 18 months of work into it. So we're really proud of it and pretty keen to see how it's implemented and the uptake. And then the Adelaide Institute for Sleep Health are also working on some GP CBT-i education modules with the College of GPs and the GP Mental Health Standards collaboration. So lots of different bits and pieces coming online, so you won't be able to avoid education opportunities over the next 6 to 12 months, I'm hoping.
Excellent. Awesome. That looks like the rest of our questions are getting lots of thank yous through, so that's wonderful. And as we mentioned, all the resources and the courses that Eliza mentioned, we'll send you the links to all of those so you can have a look at them yourself. But thank you so much for attending this evening, and you will get a pop-up at the end of this session asking you to complete that survey. If you could do that, that would be super helpful for us. But thank you so much for just taking the time out of your evening. And thank you so much, Eliza and Alex. That was really wonderful.
Pleasure. Thanks. I know you're also busy. It's remarkable that you find the time to come and listen to these things. So yeah, thank you.
Awesome. All right. Have a great night, everybody.
Thanks, everyone. Thanks, Eliza.
Bye.